notification which is coming on your laptop, you please keep it on silent. Shantanu sir, are you starting from your end?
Yeah, I think I will start off and then hand it over to Dr. KK.
Okay, great. So what I'll do is I'll give you a count. Let's say 3, 2. Sir. Okay,
Yes.
perfect. So do you want me to start right away?
I think we just, I just had a word with Nehal. Nehal, are we good or we wait for a couple of minutes?
Sir, we are good, but again, I think so, Doctor. Again, if you go back, it was going backside. So now it is okay. Now this position is okay.
This is okay. Don't worry. It's in the outside camera, but not in the computer camera.
Okay. So, sir, Shantanu, sir, you can start. Right,
Okay.
After the Nazir gives you a countdown. Right.
All right, sir. So I'm just setting it up, and a moment. All right, sir. Are you ready?
Yes.
Okay. Here you go. 3, 2, 1. You are live.
Hey, good evening, everybody, and hello and welcome to this very interesting evening conversation on inflammation, the enemy within. Today is perhaps a very important day, I would say, as perhaps all days, especially these days, are, as we perhaps face a very, very unprecedented second wave, so-called, of the virus. In fact, last year, I remember when we had Dr. KK, Dr. Mohan joining us for a conversation on the coronavirus pandemic and a discussion of similar nature. We had almost 20,000 doctors, a record-breaking 20,000 doctors who attended that program. I think as a country, we have learned significantly in the last 1 year. But what has happened over the last 1 month gives us a feeling, an eerie feeling, that we have perhaps haven't learned enough. In fact, a very popular message doing rounds on the social media these days are, if you've blamed China for the first wave, this time it's us. I think this pandemic is really kind of a roller coaster ride. Right now, there is a bit of a panic. Just to share facts, I live in Bombay. In my own housing society, we have had 25 live cases, 3 deaths in the last 7 days, something that we have never seen in the last 1 year. And I'm sure the situation isn't very different in many other parts, in many other cities, including the city that Dr. Mohan or Dr. Agarwal comes from, the 2 luminaries that we have for this evening conversation. Doctors, we thank you once again for joining this evening conversation. And I have with me none other than Dr. KK Agarwal, who has been in the forefront in the crusade against diabetes, in the crusade against this coronavirus pandemic, and helping spread the awareness about the various pros and cons of what the virus does and perhaps it doesn't. And especially this evening, since the topic is all about inflammation, the enemy within, We have two more panelists, which I'm sure I want Dr. Agarwal to come over, take over the session, introduce the and rolling for a very, very interesting evening conversation. Sir, once again, welcome to this to this evening webinar, and please take over the session and let the conversation start. Thank you, sir. Over to you, sir.
Thank you, Shantanu. Thank you, Ares. Thank you, Royal College of Physicians, who is endorsing this program. Thank you, IGCP and Heart Care Foundation of India for co-organizing this event. The event is important at a time when India is seeing number of cases, something like 230,000 patients every day. So, stage control the virus. We are in a mitigation phase. So there is no way you can control the virus now. The only thing you can do is to reduce the mortality. And that's what our seminar is. To reduce the mortality, you need to understand what the virus is causing inside our body. Remember, it's death. It is my response to the virus, which is death. Why? Because this virus is immunogenic. This virus is immuno-inflammatory. This virus is immunothromboinflammatory. So when the virus enters the body, uses different types of reactions. One is we have a free radical injury, we need antioxidants. It responds inside, outside the cell. It CD4 and CD8 lymphocytes, which is gamma interferon related inflammation. So therefore, inflammation by some degree of immunomodulators. That enters the cell, causes TLR and NLR, that is toll-like receptor. I always need to pay toll tax when you enter the cell, that's TLR. And when you enter the cell, you use a nuclear factor kappa B pathway signaling, and then you produce various types of cytokines. So you need to modulate intracellular inflammation. Apart from that, this virus also leads to recruitment of neutrophils after 5th day. On 5th, the GF-beta, and there is interleukin 17 and 22 production, which causes. So at this moment, if we really want to prevent this particular mortality, we need immunomodulators, which does not allow my virus to enter in. I need immunomodulators. If my virus enters in, they reduces my free radical injury. I need immunomodulators to suppress my various types of immunoinflammations, which can be Th1, Th17, which can be PLA2 pathway or arachidonic acid pathways. In these pathways, I need to block the inflammation, and simultaneously, I also want to block the thrombosis as a result of the inflammation. This inflammation, normally we call them as a friendly inflammation, because we need this inflammation to tackle entry of any virus in our body. But if this inflammation gets dysregulated, with a vaccine, we have another inflammation coming in, and that is Th2 response. But that's not the subject today, because that's an allergic response. We are talking about virus, my reaction to the virus. How do I prevent its exacerbation or its dysregulation? And if I do that, I may be able to reduce the mortality. Remember, we are in a mitigation phase. Our job is to reduce the mortality somehow. And here we will be talking about which segment. There is only one segment where the mortality is high, and that is cardio-diabeto-metabolic segment of the society. There is a twin pandemic going on. and that is baseline. We are diabetic or metabolic syndrome society, pre-diabetic, diabetic, pre-metabolic, and related disorder. That's the one we need to save them. Two, we need to have some immunomodulators to combat this inflammation. For this, let me introduce two distinguished speakers, Dr. V. Mohan. He is a Padma Shri awardee. He is the chairman and chief of diabetology and Dr. Mohan's Diabetic Specialty Center at Chennai in South India, a WHO collaborating center for non-communicable disease prevention and control, and an IDF Center of Excellence in Diabetes Care. He oversees a chain of 52 diabetic centers across 9 states in India and has over 480,000 registered diabetic patients in his center, much more than combined my followers, which are nearly 10,000 less than his numbers on YouTube and Facebook combined. So I have a followers of around 470,000 and he has 480,000 families registered with him. He is also president and director of Madras Diabetic Research Foundation, which is Asia's largest standalone diabetic research center. So he will speak on inflammation, metabolic syndrome, and diabetes. Remember, metabolic syndrome is now a twin pandemic occurring in the country, and you can diagnose diabetes much earlier if you detect metabolic syndrome. Once he speaks about it, then the session will be taken by Dr. Peter Rossing, who is the head of complications research. See, complications research, not research. Much beyond that. It's not a basic research. Chief physician, Steno Diabetes Center, Copenhagen, Denmark. He is a clinician researcher developed to complications in diabetes with a focus on renal and cardiovascular complications. So the role of C-reactive protein and all types of immunoinflammation comes. He obtained a specialist degree in internal medicine and endocrinology in 2004. Since 2007, he has been a chief physician and manager of the Steno Diabetic Research Center research team dedicated to the research of micro and macrovascular complications of diabetes. So we start with a presentation with Dr. V. Mohan. Once his presentation is over, we will have a presentation by Dr. Peter Rossing in a continuation. Then I will be interacting with both of them. And after that, we will take up questions from the audience. Over to Dr. V. Mohan.
Thank you, Dr. Agarwal. Let me try to share my screen. I hope you can see my slides.
Yes.
Yeah. Okay. So thank you, Dr. Agarwal. So nicely and so lucidly you have summarized almost the whole of immunology and inflammation. Only you can do it in this such a nice manner. And today my job is to talk a little bit about the background of inflammation, metabolic syndrome, and diabetes. And I'll briefly go through some of the points which you've already highlighted. First of all, to start with the basics, metabolic syndrome has already been mentioned by Dr. Agarwal. It's a controversial term because people say when you have all these, why should you call it? You cannot get away. Can add the pro-inflammatory state and the pro-thrombotic state, which Dr. Agarwal just nicely alluded to. Why are we bothered about the metabolic syndrome? Because it predisposes people to two things. One is to type 2 diabetes, although glucose intolerance is included in that. But those who have the metabolic syndrome are definitely much more prone to get type 2 diabetes. And equally importantly, they are also more prone to develop cardiovascular CVD. So it's still a debate whether you really need a metabolic syndrome, because each of these anyway have to be treated. You have dyslipidemia you have to treat, obesity you have to treat, diabetes you treat, hypertension you treat, and the pro-inflammatory state you treat. But still, I think as a clinician, it's still a very useful concept, because as you sit in a clinic, if you just see somebody with a big waist come in, you already know this man has metabolic syndrome. Whether he has 4 out of 5 or 3 out of 5, it really doesn't matter. But he must be having, or she must be having, at least 3 or 4 of the abnormalities, if not all the 5. And that is why it's very important. And the sum is whole is greater than the whole is greater than the sum of its parts. Now, metabolic syndrome, taking it to the next level, there is inflammation of the adipose tissue. Now, adipose tissue is not an inert substance. It's not just fat which you're seeing. And that's part of that fat is actually protective. Some of the subcutaneous fat, unless you have that fat, you're not protected. And it's the nature's of protecting you. But then if you have increased fat, and if that fat gets inflamed, it is called as adiposopathy. So it is a kind of inflammation, and this leads to various the various toxic products being produced, which include free fatty acid intermediates, various pro-inflammatory cytokines, including Tnf Alpha, tumor necrosis factor, MCP1, which is monocyte chemoattractant protein, IL-6, activation of the Tnf Kappa B dependent pathways, which Dr. Agarwal just mentioned, and of course the reactive oxygen species, which leads to oxidant stress, and the free radicals. These are all also linked to insulin resistance, which is a central hallmark of metabolic syndrome. And it's from this insulin resistance that diabetes develops when you have a little beta cell failure, or if you have the other risk factors for the heart, it goes to the cardiovascular pathway and produces cardiovascular disease. A word about this adiposopathy. When the adipocytes get enlarged, primarily due to calorie intake, carbohydrate intake, or high fat intake, or if you take results in visibility, and what happens is, due to this adipocyte enlargement, the microvasculature gets compression to the this produces hypoxia, which is the main tissue necrosis, inflammation, and it leads to the production of cytokines harmful. One or two of them, like adiponectin, are actually friendly ones. But when you have this adiposopathy, it's a harmful adipokines which are released. And these important adipose cytokine diabetes include fatty FFA, tumor necrosis factor, C-reactive protein, about which we'll be talking more, and interleukin-6 or IL-6. Now, each of these are described a little bit more detail here. I'm not going into great detail, but if you talk about TNF alpha, there are many studies, I'll show you some of our own, where this TNF alpha has been shown to be increased in diabetes. This leads to this atherogenic dyslipidemia. And the clinician's point is that, which you should know, is that zinc can suppress the TNF alpha induced NF kappa B activation, and vitamin C also decreases the LPS induced pro-inflammatory cytokines like TNF alpha. Talk a little more towards the end of the talk. Talking about interleukin-6, we know that this also is something which is related to inflammation and to all the things that we talked about earlier. And again, it is known that zinc supplementation reduces IL-6, that vitamin A or retinoic acid induces the production of IL-10, which indirectly reduces IL-6. Vitamin C, again, does the same thing. And vitamin D has a direct role in reduction of IL-6. And that's why vitamin D became very popular during the COVID pandemic, although there are reports, some conflicting reports. But overall, it seems to suggest that vitamin D deficiency aggravates inflammation, whereas if you correct it, there is some improvement. Now, looking at some of the Indian data, I just wanted to share some things with you, because we have done quite a lot of work on this. This is one of our papers from a population-based study where we showed the association of CRP with body fat, diabetes, and coronary artery disease in our CURE study. We also showed the association of high-sense hsCRP and TNF1 alpha with carotid intimal thickness in subject with and without diabetes. So we studied normal people, pre-diabetic, and diabetic people in a population-based study, and we found this TNF alpha and HSCRP increases across these different grades of glucose intolerance. In another paper, we showed that serum levels of interleukin-6, C-reactive protein, and the vascular cell adhesion molecules and the MCP1 in relation to insulin resistance. We showed a clear correlation between that. In another paper, we showed that even a simple leukocyte count, a total leukocyte count itself, can be a kind of poor man's marker, if you will, of inflammation, because this total count going up itself is related to metabolic abnormalities in people with metabolic syndrome. Even if you take non-diabetic people, those with normal glucose tolerance, even within them, you can find that these levels are increased. This is a couple of other papers showing that increased miRNA 146A expression is linked to subclinical inflammation and insulin resistance. And again, another paper we showed that subclinical inflammation oxidation is related to gene expression levels in those with impaired glucose tolerance and diabetes. Since we have population-based studies, we compare our diabetics with matched pre-diabetics and diabetics, and always it comes out that you can show this inflammation, which I think was what this talk is all about. So I just wanted to show you that anything among the Indians, these are all little more. And that is why we get type 2 diabetes at a much younger age, and also cardiovascular disease at a much younger age than what Dr. Peter Rossing would see, for example, at the Steno. At least 20 years older will be his patients compared to ours, those who have type 2 diabetes as well as cardiovascular disease. We also know that the dysfunctional adipocytes mainly come from the white adipose tissue. And again, there's a bit of repetition here, but when you have excess of these, it leads to these cytokines and the upregulation of pro-inflammatory cytokines, including leptin, TNF alpha, MCP1, and so on. And again, a little bit of repetition that these cytokines are actually related to insulin resistance. Finally, I just want to talk about the role of gut microbiota, which is now an emerging field, because we now know that the altered gut microbiota in diabetes and obesity can affect immune cells in the gut. And one of the main things that happens is a higher production of what's called as LPS, or lipopolysaccharide, which activates the TLR2 and the TLR4, higher production of microbial metabolites, and a lower production of these short-chain fatty acids. The short-chain fatty acids, or SCFAs, are actually good. But when you have the gut microbiota being altered in people with diabetes, then you have reduced these SCFAs, the short-chain fatty acids, which leads to a reduced blockage of the interferon gamma, and thus leads to the pathways which Dr. Agarwal just mentioned. And this is just summarized here. That the exact defect that happens is that when you have that alters the gut microbiota, particularly the bifidobacterium, and that leads to increased LPS production, and this activates the macrophage, which leads to the muscle, most importantly the limb as well. And do we have proof of that? Yes, what is associated with an increased risk of type 2 diabetes, and this LPS has evolved as a very important marker, which you can see. And the LPS transport in circulation is possible in two ways, facilitated either by chylomicrons or by loss of the intestinal tight junction. So that's what happens when it starts leaking out. We actually measured this in some of our experiments in people with controls, non-diabetic subjects, and in people with type 2 diabetes. And we actually measured the LPS, and we showed that the LPS was elevated in people with type 2 diabetes. We also measured what's called as the LPS by HDL ratio, which we call as the LPS activity in control subjects and in people with type 2 diabetes. And we showed that it is markedly increased in people with type 2 diabetes. What I'm not showing here are two recent publications in our collaboration with our Danish colleagues, Professor Olaf Pedersen and our group. Two papers we had back-to-back in Genome Medicine, where the first paper we reported on the gut microbiota in Indians and Danes. This is a project, is an Indo-Danish project, and the methodology adopted was exactly the same. In fact, our people went to Denmark, got trained, and then came back and set up the assays exactly like that, and with a lot of cross-standardization. And what we showed in a nutshell, I'm not showing you because it's slightly outside this talk, was that if you took the gut microbiome of a Danish person and an Indian with or without diabetes, they are completely separate. For example, what we had in the Indian, the Prevotella and so on, are almost absent in the Danish population. And what was found there was actually absent in our population. So you can actually, looking at the gut microbiota, you can actually divide Danes and Indians into different groups. And within the Indian population, if you looked at the normals and the pre-diabetics and the people with diabetes, we were not able to see considerable differences. There was some overlap. So we're a little disappointed that we did not find a single marker of the gut which distinguishes people with diabetes and without diabetes. Although for pre-diabetes, we did find some of them being specific for pre-diabetes. But it was a very interesting paper because the interracial differences with respect to gut microbiota, I think we showed for the very first time. So I think my take-home message is my last slide, which shows that inflammation definitely plays a very big role, both in diabetes and metabolic syndrome, and of course, thereby to cardiovascular disease. And therefore, it stands to reason that by reducing inflammation, both diabetes and metabolic syndrome can be either prevented or reversed. And we're going to hear more about this from Dr. Peter Rossing and, of course, from Dr. K.K. Agarwal also. So with this, I will stop sharing my slides. And hopefully,
Thank you.
Get back to where we are.
Thank you, Professor Mohan. And now I'll invite Dr. Peter Rossing to give a presentation before we discuss.
Thank you very much for the opportunity to be here with you. It's a great honor and pleasure for me to be in this session and talk on this important topic on inflammation, the enemy within. As you alluded to in your introduction, my focus has been complications, so I'll talk a little bit about how targeting inflammation can be important in relation to targeting complications in diabetes. And as we just heard before, metabolic syndrome, hypertension drives a pro-inflammatory state. And before we heard about the relation to type 2 diabetes, and I'll focus more on the cardiorenal complications and how to try to intervene targeting the inflammatory pathways. First, mention that there are, as we also heard before, many of these important inflammatory adipokines, like the free fatty acids, both in the adipose tissue, and we also heard about the importance of the gut and fatty acids in the gut. We heard about Tnf Alpha, CRP, and IL-6. And I'll not talk, as I said, so much about type 2 diabetes, but I'll start by showing these data where in the CANTOR study, which was a trial targeting IL-1 with an antibody, 10,000 people were included in that trial. It was a cardiovascular outcome trial, but a secondary outcome was to look in the 6,000 patients without diabetes if the different markers of inflammation were associated with progression to diabetes, and also if targeting inflammation could reduce onset of diabetes in this population. As you can see here to the left, both the levels of high sensitive CRP and different tertiles, or IL-6 in different tertiles, were associated with an increased risk for development of type 2 diabetes during 5 years of follow-up. On the other hand, if the IL-1 beta inhibitor canakinumab was tried to or applied in this population, it could not reduce the incidence of diabetes. That's of course not the same as saying that inflammation is not important for of diabetes, but just this way you cannot reduce. That was the primary endpoint. That was the cardiovascular outcomes. they were reduced whether you had diabetes, pre-diabetes, or normoglycemia. So with no interaction between the different glucose states, targeting inflammation could reduce cardiovascular outcome in this population. And we have worked a lot with how hyperglycemia, obesity, hypertension drives different pathways, like in addition to the metabolic or the inflammatory, fibrotic, oxidative stress pathways, leading to changes in the cardio and renal status in our patients. And we have worked with different biomarkers that can be associated with development of cardio and renal complications. And very interestingly, going back to the introduction of Agarwal, many of the biomarkers that are associated with development of cardiorenal complications in diabetes are also markers of an adverse outcome if you have a COVID-19 infection. Going to the kidney, in diabetes, we talk about glomerular disease driven to a large extent by inflammatory changes in the glomerulus, where in the mesangium there's accumulation of inflammatory cells and a lot of inflammatory mediators driving the mesangial expansion and the damage to the glomeruli and causing eventually renal failure. And therefore, you could say potentially targeting inflammation could be beneficial in kidney disease in diabetes. First, this is a panel which was published relatively recently from our colleagues in Boston, Królewski and Monica Newcas. They looked at inflammatory markers in plasma, and they developed a panel of 21 inflammatory markers, very much related to TNF pathway, TNF receptors, but also IL, different interleukins, as you can see on this slide, that were associated with progression to end-stage kidney disease, both in type 1 diabetes and in type 2 diabetes cohorts. And I'll come back to why I showed this pathway in a few seconds. But first, showing you a bardoxolone effect on kidney disease in diabetes. Bardoxolone is targeting the inflammasome in the kidney. The Tnf beta is being targeted by bardoxolone, which is the only agent that has actually increased renal function in patients with diabetes and kidney disease in the BEAM and Beacon studies that were conducted some years ago. Unfortunately, bardoxolone had a side effect of heart failure and fluid due to fluid retention. So probably you would need to very carefully select patients that are eligible for this treatment and can tolerate it without getting side effects, or you need to combine this treatment with a diuretic treatment or maybe an SGLT2 inhibitor. Now, targeting the inflammatory pathways in kidney disease, the JAK-STAT pathway is important. It was pointed out from animal studies because there was overlap between pathophysiologic upregulated pathways in animal models, in kidney biopsies, and in human kidney biopsies. So it was suggested to target this with an agent biicitinib. And a human study was conducted here by Catherine Tuttle, and the slide shows at 12 weeks, 24 weeks, and after washout, that increasing doses of biicitinib blocking the JAK-STAT inhibitor could reduce albuminuria with up to 30%, which we consider a good sign of kidney protective benefit. And coming to the CRIS or kidney inflammatory panel I showed you before from Boston, it's very interestingly that our standard of care, losartan or the angiotensin II receptor blocker, in the top is not changing any of these biomarkers related to inflammation, whereas biicitinib, this anti-JAK-STAT pathway agent, really lowered many of these inflammatory markers, suggesting that you had a reduction in albuminuria. It was associated with this reduction in inflammation. Now, very recently, I was part of the Fidelio trial, and the Fidelio trial was a large renal outcome trial targeting inflammation and fibrosis in kidney disease and diabetes. You can say we are targeting hemodynamic and metabolic pathways as standard of care, but inflammation and fibrosis is not really targeted. And inflammation and fibrosis is partly upregulated due to upregulation of the mineralocorticoid receptor pathway, which leads to kidney and cardiovascular damage in our patients. And finerenone is a new mineralocorticoid receptor antagonist. It's a non-steroidal compound, and it is able to block this overactivation of the mineralocorticoid receptor. And therefore, you could say the idea would be that blocking the mineralocorticoid receptor would lead to kidney protection. First, some experimental data where finerenone compared to the steroidal MR antagonist eplerenone is reducing different inflammatory markers and fibrotic markers in these animal models more than the eplerenone. And if you go to a model of cardiac fibrosis, also in animals, there is less cardiac fibrosis with finerenone than with eplerenone in doses that have similar effect on sodium and blood pressure. Now, going to the human study, first summing up that this finerenone in experimental pathways, well, it acts on pro-inflammatory mediators, pro-fibrotic mediators. It acts on the bone marrow, the monocyte macrophage activation, and thus in different ways potentially could protect the kidney. And if you go to the Fidelio trial, which was enrolling almost 6,000 type 2 diabetic patients with a GFR of 25 to 75 and micro or macroalbuminuria followed for 2.5 years, with the primary endpoint, a typical kidney failure endpoint with either 40% decline GFR or kidney or cardiovascular death, or a secondary cardiovascular outcome with MACE or heart failure, and tertiary endpoints like death and hospitalization for other causes. Well, you can see that this finerenone blocking inflammation and fibrosis on top of RAS blocking therapy in these patients with proteinuric type 2 diabetes reduced the kidney endpoint, kidney failure, 40% decline in eGFR, or renal or cardiovascular death with 18%, which was highly significant. And in the different subgroups that were analyzed, there was very consistent effect in different subgroups. And if you look at the secondary cardiovascular endpoint, also this agent reduced the cardiovascular outcome with 14%, which was also significant. And this was without affecting glucose levels and without affecting blood pressure levels. So it is probably due to an anti-inflammatory or anti-fibrotic effect that you have this reduction in both the kidney and cardiac events in type 2 diabetic patients with proteinuria. Later this year, we will have new data from the Figaro trial, which is even larger with approximately 7,500 individuals also randomized to finerenone or placebo, but that's in earlier kidney disease, type 2 diabetes. And in that study, the cardiovascular outcome is the primary endpoint and renal outcome is the secondary endpoint. And it's going to be presented later during this year. So we look forward to that. And with that, I'd like to sum up and say that glucose intolerance, hypertension, obesity leads to a pro-inflammatory state, which causes diabetes, as we heard before, and then causes chronic kidney disease and cardiovascular disease, and that we can, by target these inflammatory pathways, it seems we can actually reduce the burden of complications in diabetes. Novel agents are being tested, and we need to find maybe and apply novel biomarkers to identify those people that really need these anti-inflammatory treatments to get the most benefit out of these new treatment opportunities. And with this, thank you very much.
You, Dr. Mohan and Peter, for beautiful elaboration on the concept of subclinical meta-inflammation in cardiometabolic disorders. And this virus has told us very clearly, take care of your meta-inflammation. Otherwise, I'll convert subclinical inflammation into flare it up with a fully evident inflammation. So all those cases in the COVID era, we have seen very clearly that if they have no subclinical meta-inflammation, they respond better with COVID-19. They don't end up into complications. But if your subclinical inflammation is there, means CRP between 1 and 3 or 3 and 10, and so we expect them to increase their meta-inflammation, and that causes increase in IL-6 and fibrinogen, leading to early Th1 response and delayed Th17 response, leading to complications of COVID-19. And that's the reason why COVID-19 is more serious in patients with underlying cardiometabolic disorders. So I come back to Dr. Mohan first. And my first thing is that I now need to protect myself before I get COVID, or if I develop diabetes, I need to protect my inflammation. So if I need to protect my inflammation, I need to work at the level of reactive oxygen species. I need to work at the level of cellular inflammation and extracellular inflammation. And we know zinc is acting at various levels, but predominantly zinc acting at the level of intracellular inflammation, which reduces nuclear factor kappa B pathway, which reduces formations of interleukins. So how important is zinc? At what dose? Pre-diabetes, metabolic syndrome, post-diabetes, diabetic with COVID, and other things. Dr. Mohan.
Thank you, Dr. Agarwal. I think in the case of diabetes, it's a multifactorial thing. So in diabetes, always that is a problem. It is not one single factor, but many factors which contribute to this. And we also know that people with pre-diabetes itself have a lot of these inflammatory changes. In fact, we have also shown that even when you don't reach the stage of pre-diabetes, but you have normal glucose tolerance, but your 1 hour value alone is elevated, where the fasting is normal and 2 hour is abnormal. Already there, the inflammatory changes already exist, and you can show something like a pre-diabetes stage even at that stage. So that if you have everything normal, the fasting normal, 1 hour normal, and the 2 hour normal, they are very different from ones who have fasting and 2 hour normal, but in the GTT, the 1 hour sample going up, they are already having the inflammation. And then if you go to pre-diabetes, the cardio, as they say, the clock starts ticking right at the stage of pre-diabetes. Then, of course, in diabetes, it's even worse. So when we talk about controlling the factors for diabetes, I think the first thing will be the control of diabetes itself. So if you keep your A1Cs down, I have reviewed some papers which show that somewhere around, even within people with diabetes, HbA1c around 8.5 or higher seems to have very bad outcomes as compared to people who have their A1Cs near 7 or below 7. So the first thing I would say is for people with diabetes, control your diabetes well. Many people have started doing that because even during the first wave of the epidemic, because of the fear, many of my patients started doing more SMBG testing, which they were not doing earlier. Similarly, today we have continuous glucose monitoring. So if you do that, the time and range can be brought under control, 70% or more. So if you do those two things, and of course, you also have to look after the other parameters. If you don't control your blood pressure or you don't control your lipids, then the thrombotic pathway and the inflammatory pathway still continues, and the risk for macrovascular disease does not come down. So all the three have to be controlled. Apart from that, I would say a healthy diet is also very important, because we talk about zinc. Of course, you can give zinc supplements, but then a lot of the zinc can be given in the food as well. So a lot of the legumes and some of the non-vegetarian foods and many other foods contain zinc. So you can give zinc, but then zinc supplement is important. But it's not just zinc alone. I think if you have a healthy diet, you cut. For us, one of the reasons for this chronic inflammation in Indians is the very high carbohydrate diet, because we take so much of carbohydrate that it produces chronic inflammation. So if we can increase our protein intake and eat healthy fats rather than the unhealthy fats and cut down the carbohydrate intake, that will help to improve the inflammatory pathways and improve your immunity. Secondly, exercise. Independent studies have shown, including the recent publication, that those who exercise regularly do much better. Third, there are other factors like sleep and other factors also which are very important. Apart from all that, I think correcting zinc deficiency or giving supplements of zinc, vitamin C also can be helpful, as has been shown. Vitamin D deficiency, which is very, very, very common in India, 75-80% of the population having vitamin D deficiency. I think that also has to be corrected. And if you do all of these things, I think reasonably we can see that the inflammatory pathways are kept under control, oxidant stress can be reduced, and people do very well. In fact, many of my patients who have had fairly good control of diabetes and looked after themselves, they have had COVID and just came out without anything. They didn't have even not even much of CT scan involvement. The D-dimer and other parameters, CRP was not very elevated, and they seem to come out of it just as if they had a little cold or something. And of course, today after the vaccination, also it has improved the scenario. But people with metabolic syndrome and diabetes have to be very, very careful and look after all these parameters, and then they can also do well.
So come back to Peter. Very simple that in India we have 70 to 80% of the population who is vitamin D deficient, and we don't have so much of fortification of vitamin D. So invariably, most of us, including all the doctors, because most of the time we are sitting indoors, yes, we are on a vitamin D supplement. Okay. So if I am taking a vitamin D supplement, then I need to combine it with other possible anti-inflammatory supplements. One of them is C, because that takes care of oxidation, and that takes care of free radical injury, and that works at the level of providing me an antioxidant, and that reduces C-reactive protein by itself. And then zinc is essential in COVID era and in non-COVID era because of a cellular inflammation, because of a it may not act at the level of JAK-STAT pathway, but definitely at nuclear factor kappa beta pathway, it is predominantly working. So why not combine all three of them? When I have to take a vitamin D supplement, then why not I supplement in addition to that, specifically vitamin C and vitamin D. Vitamin D, zinc, and vitamin D.
Yeah, thank you. I think it's a very good question, interesting question. And I think, again, the challenge is that we are lacking good, I would say, intervention studies showing that this really is helpful. That's not the same as saying it's not helpful, but just that it's difficult to conduct such studies. And in Denmark, we have also low levels of vitamin D because we are to the north and we don't get much sun during most of the year. So we have fortification, or people have supplements, and usually people have multivitamin supplements with trace elements and all the different vitamins, antioxidants. But studies really showing to what extent it helps has been difficult to do, and I think some of the studies have failed to show a benefit. And the discussion has been very much, is it the supplements, or is it, as we heard before from Dr. Mohan, is it if you get these things through the diet, is that a better way of getting this than getting it as supplements? And I don't think we know for sure which is the optimal way. But I think, as you point out, we are in a state where we are lacking these beneficial factors unless we either get them through our diet or through supplements. And in many parts of the world, it is difficult to get through the diet. But And in that situation, supplements can indeed be probably helpful.
My contention was not about the difference between diet and supplement. My contention was when you are giving a supplement, because specifically for vitamin D, when you are giving a supplement, then why not combine it with, when you're giving vitamin D, why not combine it with C and zinc? That was my contention with that. So another thing which comes is that now we are moving from extracellular inflammation. One is the intracellular, which is you have signaling pathways, you have TLR and NLR pathways, inflammasome, pyroptosis pathways. But I'm talking about extracellular pathways. We have Th1 response and we have Th17 response. Th1 is lymphocytic recruitment and Th17 is neutrophilic recruitment. Normally, Th1 is antiviral, but Th17 is normally supposed to be antifungal and antibacterial. But we have now started seeing Th17 response after the vaccine, and now we presume that if it is occurring after the vaccine, it should have occurred because of the virus also, because vaccine is nothing but the same spike protein. So we have started now observing lots of IL-17 or IL-22 inflammation. And there also vitamin D is the only natural IL-17 inhibitor available. So if we want to control extracellular inflammation early, which is Th1, delayed, which is neutrophilic recruitment, as Dr. Mohan said, that you can see the lymphocytic response. So we have started seeing after the vaccine that on day 4 and day 5, we are seeing more neutrophilic recruitment with NL ratio rising. So there the role of high dose of vitamin D may also come. I would like both of you to comment on that, Dr. Mohan and then Dr. Picha.
Yeah, I definitely agree, sir. In fact, today it's very sad that one of our Tamil actors died this morning, as you might have heard. Actor Vivek, a very popular actor. And he had taken his vaccination only a couple of days before. And this is Covaxin, not even Covishield, which is known to produce. And I used to say that Covaxin, may have less effect, but also less side effect. But and of course, they are saying it's nothing to do with the vaccine. They have, the doctors have said, very unlikely and so on. But 2 days, less than 24 hours, 48 hours later, and I've heard you talk on this several times, and the collection of cases that you have collected after the vaccination, I don't think anyone in the country has got. So you have collected almost 700, 800 such cases when we last met. I cannot rule it out that there's something to do with the vaccination, and that is how he died. So must be some kind of a reaction. The only problem is, from a practice, we can introduce this. We can tell all our go, you take, you mentioned colchicine in one of the other meeting, or you can take an extra dose of clopidogrel or clopidogrel or aspirin or something, and vitamin D, you can take a sachet of that and then go. And we don't have evidence though. And as Dr. Rossing said, to do a study on this now is going to be a nightmare. How do you do a control study? How do you do this? How do you monitor these people who are all going to vaccination? My bigger problem is there's nothing wrong. After all, vitamin D, even if you have normal vitamin D, if you take a little vitamin D, you're not going to get toxicity because you're not injecting vitamin D in 300,000 units. Even the maximum you're going to take some 60,000 units, which is not going to do any harm. So I don't think in principle it's wrong to do that. I have the two issues which I have is when you're rolling it out to 1.3 billion people, how do you get everyone to either do a test? How do you get them to all to take vitamin D, and how do you get that? That's my first problem. And the second problem is they'll say, where is the science? Where have you proven that by doing this, they didn't get the clot? The next 1,000 people, you show that they didn't develop the clot. It is very difficult to do in a real life situation when you're ramping up the vaccination and doing, several 100,000 in a day when you're doing, it becomes difficult. But from a theoretical point of view and from a practical point of view, if this is going to help give even 5% protection, they are safe, first of all. So nothing will go wrong. If you take it, no side effect is going to come. And if it's going to help, theoretically, it makes perfect sense. And so only thing is, if scientifically they say prove it and show it, we may not be able to prove it immediately. Maybe there are studies going on, and maybe we may develop that in small centers. Maybe we can collect some series and then prove it. And I think this definitely needs to be done. But if there's anything that can be done to protect this, 1 in 100,000 people from developing this and often even leading to death, I think it is very much needed.
So I want to add here, when the Ram Mandir issue came in the Supreme Court, they relied on the scriptures.
Yeah.
The whole decision by the Supreme Court was relied on the scriptures. So we have Manu Smriti, which talks about the origin of evidences, from where came the Indian Evidence Act. And they say logic. So the first evidence is logic. In fact, the first two evidences are logic, which are called Nyaya and Vaishashik. And then comes his observations. So we have a logic, we have observations. Then comes his the first Anuman and Upaman. These are the next two, then Mimamsa and then Shabda. So these are the 6 different types of evidences. So in a pandemic-like situation, you rely on logic and observations. You can't go for a double-blind trial. So I don't think so. So 2 evidences out of 6 are there. These are strong enough evidences from the point of view of Vedic literature. So therefore, and there is a law of Rama and the law of Krishna. The law of Ram is that you believe on evidences. First evidence is first. Krishna says anything which is not harmful may benefit, go ahead with it. As long as it is not harmful, may benefit, is cost effective, go ahead with it. I call them as a principle of Ram and Krishna for that. Myself with that.
No, I think even Hippocrates has said that, non-nocere, at first do no harm, so as long as we are sure you're not doing any harm, no harm in taking. In fact, I know, almost every patient of mine has been taking zinc, vitamin C, and vitamin D throughout the pandemic, and I never stopped anyone from taking it. I said, what is wrong? If you take a zinc supplement or a vitamin C supplement, it's not going to kill you. If it does good, well, very good. If it doesn't do good, doesn't matter. At least you tried to do something. Definitely by taking that, you're not going to go into toxicity or something like that. It's never been shown. So therefore, if some study can also come, then it's great.
As the time is less, I will hand it over to Shantanu to pick up the questions from the people who are attending this. But before that, I want to make a general comment. And the general comment is very simple. When you talked about the controversy of metabolic syndrome as a cluster of disorders, but today we know in that cluster, there is something common, and that's meta-inflammation. So it's primarily a meta-inflammatory disorder. And so therefore, it's a disease. It's a meta-inflammation is a disease. So all of you, if you like to change the definition in near future, you can convert it into from a syndrome to a meta-inflammation, anything related to meta-inflammation. Over to Shantanu to ask the questions.
Yeah, thank you so much, sir. We have indeed received several questions, but I thought, for this sake of time and purpose of this meeting, we'll pick up a few of them. So this one we received from Dr. Gupta. So Dr. Gupta asks that in this presentation, we've seen that patients with metabolic syndrome, supplementation with immune boosters like zinc, vitamin A, C, and D has shown beneficial effects. So according to you, doctor, in which other patient pool should we consider enhancing immunity? So Dr. Agarwal, sir, if you may put it up for conversation, discussion.
So I got Dr. Peter Rossing. You would like to say about that? In which patients we need to build up innate immunity, and so that we can tackle better meta-inflammation and external inflammatory stimuli.
Yeah, I think as you just said before, in the metabolic syndrome, where you have the inflammation and the related conditions in diabetes and in the cardiorenal problems related to this, I think a healthy immune system, which is sufficiently active and boosted, might be beneficial. Again, the challenge is that we are lacking good evidence, but on the other hand, we are probably not doing much harm. and probably also the background of what the population I'm seeing in my clinic and the population you are seeing might be different, and you alluded to the diet, and there are many other factors. So it might be different in different situations, but it's very common here to try to boost immune system with different supplements and antioxidants.
Shantanu, the next question.
Yes, sir. Yes, so we have a second question, which says that in the current times, it is imperative to boost immunity for all. With the initiation of COVID-19 vaccination drive, there will be need for further building up of immunity, as vaccine will perhaps further cause the inflammatory response. So this vaccinations has to be continued every 6 months, 1 year. This suggests that going forward, immunity will remain the property of humankind. Therefore, would you also, would you also suggest the chronic use of immunity boosters agents like zinc, vitamin C, D, or A?
So I'll ask it to Dr. Mohan very clearly. You talked about the film actor dying of vaccination. It is for sure that there is one thing is common between the virus and the vaccine is the spike protein. The spike protein is the same. The gene is the same. So whatever you expect with the virus, you also expect with the viral protein, which is a spike protein. So the whole can be more harmful than the smaller, the part of it, but the part of it cannot be ignored. If the whole is thromboinflammatory, the part will also be thromboinflammatory. So therefore, it becomes very important for us to talk about preventing thromboinflammation or meta-inflammation also while taking the vaccine. So therefore, we today at Confederation of Medical Association of Asia and Oceania, we talked about and came out with Simao Sutras, and which clearly says that all women who are menstruating or hormone-bearing women should take 75 milligram aspirin before vaccination. All population who are having a cardiometabolic or a high risk or a comorbid situation where we have defined CRP more than 1 should be put on aspirin prophylactically before, during, and after COVID, and before, during, and after the vaccine. And now we are also adding to that is that continue your vitamin supplements, which you have finished after COVID, continuously, because now you may need 2 vaccines, 3 vaccines. How long the effect will last, we don't know. So keep your meta-inflammation under control. Dr. Mohan.
I mean, I can't agree with you more, sir, because as we just discussed, it's not going to do any harm. And I think this point about aspirin also, I don't think there's anything wrong in it, because we know it's a pro-inflammatory state. And as you have clearly shown, there is a clotting mechanism taking place, whether it is with the Covishield vaccine or with Johnson & Johnson vaccine. I think the Sputnik one also, because that's also an adenovirus kind of a thing. So the receptor. So therefore, any of these can produce clotting. We have seen that even with the Pfizer vaccine in Norway, there were deaths. So I don't think, and today with the actor who was taken, we still don't know it's related, but I'm just saying that within 24 hours, when it's with all the other vaccines, it's come putting circumstantial evidence to say that this is not related. It's a little difficult, but we'll have to prove it until proven. Otherwise, we can't say that. So even with Covaxin now, we have seen this. So with all this, I think taking aspirin, although it's not a recommended thing now, in scientific circles, the problem is they'll say, where is a recommendation, which is a guideline, which is a thing. Everything is now questioned that way. But I think it makes perfect sense as a clinician to say that why don't you take this for, during the COVID, certainly, because having clotting mechanisms to prevent that, taking aspirin is not a bad idea at all. After all, there is one school of thought, aspirin for everyone. In a common pill, poly pill, they're talking about aspirin to give it to the whole population. So when you can go to that extent during this time, when we are all at high risk, and either due to the COVID or due to the vaccine, clotting mechanisms are being seen, I don't think there's anything wrong at all in suggesting that. And I would also suggest taking vitamin D in our population is definitely justified, because given that 80% of the population is vitamin D deficient in our population, you have studies to show that. So I think that also makes sense. And I think even giving some zinc or vitamin C generally to build up, it may not have any benefit, but it doesn't matter. You can still take it for some time, at least for another year or so, until all this is behind us. And by the time, I think some studies also may come. While we are accumulating that evidence, for example, I'll just go back, say, 1 year ago. If we just go back 1 year ago, what were we doing when we got COVID? Put everybody on a ventilator, Then we realized, this is not the problem. The problem is something else. So then all ventilators, in fact, you can imagine how many ventilators were produced in the country at that time. Thousands and thousands of ventilators were produced, saying that, and then very few people actually needed a ventilator. Then we realized it's clotting which is a problem. So once that has been realized, then the use of steroids came in. So before steroids were introduced, we did not even think of using that for that. We could have imagined at that time that steroids will reduce inflammation. It's common sense. In any acute, highly, whether it's rheumatoid arthritis or anything which is severe, we use steroids. So that is common sense. So once that study came saying, we should have done that. So now everybody has started going on. I think some of these things, that as long as steroids, can produce harm. So we cannot give it empirically to everyone. But things like vitamins and all that, I don't see there's any harm in doing it. But if we can, at the side by side, if some small studies can produce evidence, then that will also be very.
So I only want to add one thing what Dr. Mohan has said. There is a very minute difference in wordings. Died of vaccine or died after vaccine. So he died after vaccine. Whether he died of vaccine or not,
correct,
that is a matter for debate. But he died after vaccine cannot be debated.
It's difficult to prove also.
No, he cannot be debated. He died after vaccine.
How will you prove?
No. Off vaccine,
correct,
difficult to prove. But after vaccine, he died. That's the truth. He took
vaccine. After vaccine, there's no doubt. 24 hours later, if you die, it definitely is after vaccine. So
there is a truth in that he died after vaccination.
That is true.
He died of vaccination.
And see what happens. What happens in medicine is you see a common trend emerging. So you will find, a lot of clotting is happening. So it must be related to that. That's how evidence is created. When the first case comes, we'll say, no, this is just chance. The second one, 10th one, 100th one, 1000th one come. It cannot be chance. 1,000 people developed a clot by chance. It cannot be.
If somebody asks me how to prove what might have happened, not what might have happened, one of the option is that he has underlying coronary blockages. He has a dimple in the pimple phenomena. He has a vulnerable plaque. He has a fibrous cap of less than 0.65 nanometer. There was M1 macrophages sitting there. The corona vaccine came. It introduced M1 inflammation, which precipitated or triggered the rupture. That's it. It cannot cause, it can trigger. That's the only way you can explain. Otherwise, there's no way to explain that. So let me ask, because our time is short, can I ask Shantanu to sum up and close the meeting?
So just two more very short ones, but I think, this is a genuine query of a doctor, and therefore, if you can just help this one. So this, I will club these two questions. One is where the doctor asks, do you think, Dr. magnesium is also useful? And secondly, another question is, what amount of vitamin C is actually absorbed if it is taken orally?
Sir and Dr. Mohan.
Dr. Agarwal can.
I know.
Okay, so magnesium deficiency, started testing for magnesium, we do find. And then we know that magnesium deficiency is related to insulin resistance, it's related to diabetes, and we know that the insulin resistance improves if you correct magnesium deficiency. So if there is a deficiency in magnesium, you can treat that. Another big indication I find for magnesium is cramps. Nocturnal cramps improve a lot when you give magnesium. We have treated many patients with cramps, and once you supplement the magnesium, the cramps goes away. So there is a role for magnesium, but I don't think, blanket giving magnesium to everyone is indicated, because magnesium level is normal. I don't see what help that would need. It's not as much, widely used as, say, zinc and so on. So I would be a little cautious to give it to across the board to everybody without knowing what it can do. But definitely magnesium deficiency is quite common. It is very common in people with diabetes, and it's related to insulin resistance as well, and some amount of inflammation.
Peter, you want to add something? Otherwise,
no, I think it has also been related to complications in diabetes. So I think it's a relevant point, but I also agree that we should not just give it to everybody.
so I just want to end by saying, Shantanu, that in India we have an epidemic of vitamin D deficiency. Amongst vegetarians, we have a semi-epidemic of B12 deficiency, and these two require supplement. And if you are taking supplement and if you are prescribing supplements, then look for supplements which can give you other possible vitamins and nutrients which otherwise would have been deficient. So whenever you are taking a supplement, try to see, can I get one or two which gives me most of my requirements. Over to Shantanu to close the meeting.
Yeah, thank you very much, all of you, Dr. Peter, Dr. Mohan, and of course, Dr. Agarwal. I really, really appreciate, this conversation this evening. And I think we've addressed the growing concern of doctors, and I think very importantly, a lot of reassurance from what I heard regarding the vaccination part. Both you, Dr. Mohan, have given enough confidence that yes, and I think even in social media posts of both of you we are following. I think this would definitely be useful, very helpful for all our doctors who have attended and very eagerly waiting for this evening conversation. So thank you all very, very much. I really appreciate your time and your expertise in helping us in this crusade against this pandemic, and hope and pray that this current wave that you started with 230,000 should soon start seeing downward spiral. So with that hope and stay safe, very importantly for all of us and all our doctor colleagues who have joined in this evening. Thank you very, very much on behalf of Eris Life Sciences. This is Shantanu. Once again, thank you very much and God bless. Take care.
Bye-bye. Thank you.
Bye-bye.
Thank you.
Thank you.